Oh, welcome everyone. We're delighted to see so many of you joining us today. My name is Dr. Molly Waring. I'm an associate professor here in Allied Health Sciences and involved with InCHIP. I am also the chair of the Pregnancy and Postpartum Health Research Interest Group through InCHIP, which I suspect may be of interest to some of you since you're here. I will drop a link to our rig in the chat, so anyone who's not a member and would like to be has easy access to it. A little bit of housekeeping before I introduce our speaker. We will be muting everyone during the talk, but if you have questions that come up during the talk, feel free to put them in the chat. After the talk, which will be about 45 minutes, we'll have a period of Q&A, and you're welcome to unmute yourself at that point and ask questions via voice or put your questions in the chat, and I'm happy to voice them. So with that housekeeping done, I am delighted to introduce our speaker. Dr. Rafael Pérez-Escamilla is a professor of public health at the Yale School of Public Health and serves as the director of the Office of Public Health Practice, the Global Health Concentration, and the Maternal Child Health Promotion track there. He is also the PI of the Yale-Griffin CDC Prevention Research Center. His program of research focuses on global public health nutrition and food security, and findings from his studies have contributed to improvements in breastfeeding, iron deficiency anemia among infants, household food security, and early child development among his target populations. He has co-led innovative mixed methods implementation research studies assessing the impact of community health worker-delivered person-centered interventions on breastfeeding, type 2 diabetes, postpartum hypertension, and mental health outcomes among vulnerable communities. As acknowledgments of his contribution to science, he was elected as a member of the U.S. National Academy of Medicine in 2019. And we are delighted that he has joined us today to talk about the impact of neocolonialism on global maternal and child health. So take it away. Thank you.
Thank you very much, Molly. And I am very, very happy to be back at UConn. I was a faculty member for 15 years with the Department of Nutritional Sciences in Stores, and I still live here with my family. And I am very pleased to talk to you about the case of the infant formula industry as a great example of how neocolonialism has negatively impacted global maternal and child health. And my presentation is very heavily influenced by the 2023 Lancet breastfeeding series, of which I was a member of the executive committee as well as a co-author. Okay, so I will first talk about colonialism and the commercial milk formula industry, to then move on to a very important document that has not been used enough to National Code of Marketing of Breast Milk Substitutes. And then we will talk about why, from a public health and human rights perspective, this matters so much given the importance that breastfeeding has. And we'll move on to talk about the structural barriers to breastfeeding and how the commercial milk formula companies take full advantage of the neo-colonial structures to really market their products following very dubious practices. And we will conclude with my reflections on the. So let's start with colonialism and the commercial milk formula industry. And I strongly encourage all of you who are interested in the topic to read this very recent paper from Cecilia Tomori and Oncholi Palmquist, where they cover in great depth this topic. As a result of colonialism, massive profits have been generated by exploitative extraction of wealth from the global south and redistribute out the global north via routes and systems established during European colonization. Multinational and transnational corporations, including the commercial milk formula industry, continue to capitalize on these same systems to maximize profits, oftentimes at the expense of public health. We cannot talk about this topic without talking about the company Nestlé. And let's talk first about how it came about that they came into the commercial milk formula business. Nutritional science and its integration into colonial medicine set the stage for commercial milk formula companies to be for commercial milk formula to be introduced as a solution to address nutritional deficiencies observed among millions of babies at the turn of the 20th century. Medical authorities' increasing influence on infant feeding in Europe secure its reputation as a de facto humanitarian organization, supposedly to assist colonial health in addressing infection and related. From the mid-1920s, Nestlé was able to gain the trust of Swiss physicians by promoting and marketing their products directly to them and securing collaborations with them. Following World War II, Nestlé cultivated commercial and research partnerships with colonial doctors who were under increasing pressure to deal with food insecurity and hunger. Health professionals, non-governmental organizations, and the public increasingly view these commercial milk formulas as a solution to infant malnutrition. These partnerships with colonial actors opened the door to a new market in which Nestlé could promote commercial milk formulas throughout the African continent. Nestlé continued to diversify its marketing strategy, taking the promotion of its products out of the clinical settings and straight into the communities. In fact, among the most notorious and alarming practices was the use of salespeople dressed and acting as healthcare providers, the so-called Nestlé nurses, who were trained to deliver commercial milk formula marketing messages directly to pregnant and lactating women. These messages were intentionally misleading and designed to cause women to stop breastfeeding and impose their dependency on commercial milk formula products. Nestlé provided free samples of formula to lactating women just long enough to disrupt lactation. Most of these women were highly impoverished and lived in severely economically depressed environments across the African continent, Asia, and Latin America. The conditions of formula feeding were catastrophic, with a toll of Nestlé's marketing on both disruptions to breastfeeding and subsequent effects on millions of infants' death, as it has been documented as part of what we now refer to as the baby killer scandal. This is why Nestlé's began to be boycotted and the code of marketing of commercial milk formula products came in. The so-called Nestlé baby killer controversy and subsequent boycotts over its unethical and predatory marketing tactics have been extensively documented and analyzed. Global outrage over the Nestlé's corporation economic and physiological exploitation for profit led to collective action for human rights policy known as the International Code of Marketing of Breast Milk Substitutes, that we oftentimes refer to it as the WHO code or simply the code, that was adopted in 1981 by the World Health Assembly. At this point, I want to note that while Nestlé's conduct has been documented in the greatest detail, similar tactics along well-worn colonial paths have also been used by other commercial milk formula companies. So what is the International Code of Marketing of Breast Milk Substitutes, and how did it come to being? So the code is in essence a set of guidelines established by the World Health Organization to regulate the marketing of breast milk substitutes like infant formula. To protect and promote breastfeeding by restricting promotional activities that could discourage mothers from breastfeeding and ensure proper use of substitutes when necessary. Essentially, it is an international health policy framework designed to safeguard breastfeeding practices by controlling if and how commercial milk formulas are marketed. The underlying basis of the code is the belief that the health of babies is so important that the usual rules governing market competition and advertising should not apply to products intended for human beings in this tender age. Therefore, all governments are called to legislate the marketing to prevent commercial interest from damaging breastfeeding rates and the health of their population. Also set standards for the labeling and quality of commercial milk formula products and for how the law should be implemented and monitored within countries. Restricting marketing does not mean that the product cannot be sold or factual and scientific information about them cannot be made available. Nor does it restrict parents' choice. It simply aims to make sure that the choices are made based on full and impartial information, rather than misleading, inaccurate, or biased marketing claims. It is as important for women who choose to breastfeed as it is for those that choose commercial milk formula feeding. In other words, the code is really important for both of them, simply because we all have the right to receive truthful information, no matter what our choices are. While the code is not legally binding, countries are encouraged to implement its principles through national legislation and enforce it through very clear regulations. I want to mention as a very important historical fact that the World Health Assembly, the decision-making body of the World Health Organization, adopted the code in 1981. The only country that voted against the code was the United States. And they did so based on the principle that the code violated the right to free speech that commercial milk formulas had. In other words, their free speech was equated with the right to free speech that humans and the population at large has. It is very interesting that the code exists because in the 1970s, Senator Kennedy and colleagues became so alarmed with what Nestlé was doing in terms of how they were marketing their products in Africa that they brought the Nestlé's top director to testify in front of Congress and explain himself why the company was behaving the way they were when that behavior was leading to millions of deaths of babies, especially in sub-Saharan Africa and other low-income regions in the world. It was as a result of these hearings that at the end of the day, the World Health Assembly agreed to set the stage to develop the code. But ironically, again, the US was the only country to vote against it. So why are we so concerned about the legacy of colonialism on the marketing of commercial milk formula products? Well, this is because breastfeeding is the best source of nutrition for infants and children. Breastfeeding promotes health and reduces medical costs. And importantly, we typically think that breastfeeding only offers benefits to infants and children, but we now know very well through very fine epidemiological studies that breastfeeding has a very positive impact on maternal health as well. The longer women breastfeed during their lifetime, the lower the risk they have of experiencing high blood pressure, type 2 diabetes, cardiovascular disease, breast cancer, and ovarian cancer, among some of the benefits. We know that no matter the level of development of the countries, low, middle, or high income countries, breastfeeding reduces the risk of respiratory tract infections and ear infections, gastrointestinal infections, for example. Breastfeeding or breast milk reduces significantly the risk of premature babies, a very, very painful and costly condition that leads to the death of the amount of tissue in the gastrointestinal tract. Breastfeeding reduces the risk of sudden infant death, reduces the risk of asthma, reduces the risk of the onset of obesity, and importantly, supports cognitive development in children that is significantly greater years down the road when comparing it against children or people who were not breastfed or just breastfed for a short period of time in early life. The World Health Organization, for this reason, and based on a lot of evidence, recommends that breastfeeding must begin during the first hour postpartum, and that it should continue to be done exclusively for the first 6 months of life. And exclusively, it means breastfeeding only. Nothing else is needed. And once complementary feeding is introduced at this age, for women to continue breastfeeding until the children is at least 2 years, the child is at least 2 years old. And this recommendation is now the same one that is being followed by the American Academy of Pediatrics, highlighting how no matter where the babies live, in which parts of the world they live, breastfeeding is the best source of nutrition for them. So why does breastfeeding offers so many benefits that really cannot be imitated, not even close, by commercial milk formula companies? Well, millions of years of evolution, breastfeeding ended up being a very complex biopsychosocial system. Human milk has the ideal composition for human infants that have very large brains and are born very immature. They require maturation, and that require maturation for a long time in the postnatal period, and that require a lot of attention and care to survive and develop. Indeed, the composition of human milk depends on the wonderful process of breastfeeding that is based on the interaction of a diet. In other words, interaction between the mother, the baby, and the ecosystem where the interaction is happening. When the mother latches the baby to the breast, the immune systems of both communicate. In other words, if the environment has led, for example, exposure of the mom to a pathogen, then she will produce antibodies or cells or will transfer cells with immunoactive properties to her milk that are very specific to protect the baby against that specific pathogen. So that's why we call breastfeeding a very important form of personalized medicine. Breast milk contains hormones like leptin, like ghrelin, that are very important for the regulation of appetite. They contain human milk oligosaccharides that are very important for establishing or seeding a very healthy microbiota or microflora immediately after the baby is born. And importantly, breast milk has live bacteria. Oftentimes, these are bacteria that are coming from the gut of the mom that is presenting to the organism of the baby so that the baby starts establishing a similar microflora as the one that the mom has developed in the ecosystem where the diet is interacting. And at the end of the day, the human milk has thousands of bioactive compounds, some of which we still don't even understand biological function is. The process of breastfeeding also determines the composition of human milk based on very well orchestrated physiological co-regulation process. So the composition of the milk in terms of nutrients changes dramatically as the baby grows and develops. Very soon after birth, the composition of human milk is much, much higher in protein, for example, than when the baby is several months old. It is also very impressive how the composition of human milk even changes during a single feeding episode. So at the beginning of the episode, the milk is more watery. 15, 20 minutes later, the milk is much more richer in fat, presumably signaling the baby that it's time to wrap up the feeding period. And breastfeeding is a process also based on establishing a psycho-emotional bond of the diet. So we cannot think simply as human milk as a product, but we need to think about it as the result of a process. Hence, both breastfeeding and human milk simply cannot be disassociated from each other. And this wonderful gift from human nature, so far we have no indication that it can be replicated with commercial infant. Nowadays, we have plenty of evidence that breastfeeding not only protects the health of the people and the development of nations, but also it protects a lot the health of the planet. Specifically, breastfeeding mitigates against climate change because it prevents the enormous amount of water footprint as well as the carbon footprint that gets left behind by the commercial milk formula industry as part of the growing of the dairy cows, the processing of the milk, the manufacturing of the formulas, their distribution, their storage, and at the end of the day, their preparation at home. So there is now a very important call that has been made based on plenty of evidence to the World Health Organization to encourage governments to invest in breastfeeding, not only as a public health measure for people and families and so on, but also as a green intervention that has a very strong impact on preventing the carbon greenhouse emissions that come out from the commercial milk formula industry. Producing 1 kilogram of dry milk also requires thousands of liters of water. So the water footprint left behind by the production of commercial milk formula is also enormous, and not to forget that the disposal of the packages of commercial milk formula leave behind millions of tons of waste every year in terms of paper, plastic, metal, and so on. So different authorities have concluded for a good number of years now that breastfeeding is by far the most cost-effective tool to promote maternal and child health worldwide, and this applies to the US, it applies to low and middle income countries. And in the Lancet series, we estimated that if we were to combine all the milk, the breast milk produced by all women in the world, every year, the economic contribution would be equivalent to $3.5 trillion, trillion with a T. Unfortunately, there is no country in the world that counts breastfeeding as part of the gross national product. So this has a very perverse effect that the more governments invest in promoting and protecting and supporting breastfeeding, and the rates of breastfeeding go up, the GMP goes down. Why? Because the production of infant formula is counted across countries all over the world as part of the GDP or gross domestic product. As a result, due to low investments in breastfeeding, the world is losing over $1 billion every day. So why is this happening? What are the barriers that are preventing women from breastfeeding? So this is a topic that I addressed in a commentary that I made about an article that was published in Social Science and in Medicine. And what I was trying to communicate is that nowadays is not only the great, but in many, many countries, the vast majority of women are choosing to breastfeed. Even in the US, it is now about 85% of women choosing breastfeeding. However, the issue is that the great majority of these women cannot express for how long they wanted to breastfeed. And when they actually ended up breastfeeding, they ended up breastfeeding for a much shorter time than what they were planning to do in pregnancy. And the question is why, and the question is what can be done out there. So to illustrate this point in our own country, a study published by the CDC with data from women enrolled in the WIC program showed that only 1 out of 3 of these low-income women were able to meet their breastfeeding goals. In other words, the great majority were not able to meet their breastfeeding goals. And it illustrated the profound social injustices that even within low-income groups prevail in the country, specifically with regards to ethnicity or race. So the darker the color of the skin, the less likely that women were able to meet their intention to breastfeed at 1 month and also at 3 months. So why? What is going on? Well, in the Lancet series, we worked for almost 3 years together, 25 co-authors from all over the world trying to make the case that it's very clear that this is mainly caused by structural barriers permeating through diverse settings that affect infant feeding decisions at the household and diet level. In terms of the structural determinants of infant feeding, we focused on political, economic, social, and technological, with a very, very strong focus on the marketing of commercial milk formula, which is what I will highlight throughout the rest of this talk, because this is the topic. So what is the playbook that the commercial milk formula industry follows when it comes to marketing practices, and what is its connection to colonialism? So the first thing I want to highlight that, as shown in this conceptual framework from the second paper of the Lancet breastfeeding series, is that when it comes to the targets of this playbook, it is very important to recognize not only directly going to women and caregivers and families, but that we academicians, we healthcare providers, we scientists are a very, very important target of the marketing playbook of formula companies. And of course, it also involves targeting governments and politicians. And at the end of the day, all of society is a target of the marketing practices. They do it through advertisement and promotion, funding professionals and science, through very heavy duty, well orchestrated lobbying through impressive networks, and by the creation of industry front groups. In preparation of the Lancet series, the World Health Organization and UNICEF conducted what is the so-called multi-country study to understand how the marketing of commercial milk formulas influences caregivers' infant feeding decisions. A decision was done to include highly contrasting countries with regards to their breastfeeding outcomes, their political structure, social structures, economic structures, healthcare systems, and so on. So the countries included were Bangladesh, China, Great Britain, Mexico, Nigeria, South Africa, and Vietnam. The data were collected between 2019 and 2021, only in urban areas. We surveyed about 8,500 pregnant women or children under 18 months of age. We surveyed 300 health professionals, conducted over 100 and conducted 80 in-depth interviews, including several with advertising executives. I had the pleasure of serving in the scientific advisory committee of this major study, not only to guarantee the scientific integrity of the study design, but also the scientific integrity of the data analysis and interpretation of the findings. So to make a very long story short, what we found through this study is that no matter in which country the study was being conducted, the industry follows a very, very similar playbook, which is not surprising as the commercial milk formula industry follows a very, very strong oligopoly-like structure with just a handful of companies controlling the vast majority of milk production and sales in the world. They do so through unregulated and invasive online advertising, industry-sponsored online mom clubs, industry-sponsored counseling and telephone support networks, by price promotion at points of sales, in pharmacies, supermarkets, and unsolicited free gifts of milk formulas, and through practices aimed at influencing the training of health personnel and the recommendations they make. Each and all of these approaches violate the code of marketing of breast milk substitutes. This is because the messages that parents and health personnel receive usually are misleading, without scientific basis, designed to play with parents' emotions in very vulnerable moments. They present as pathological what are the normal patterns of sleeping, crying, and regurgitation for the vast majority of babies in the world. And again, this is contrary to the subsequent resolutions. One approach that they now are following very heavily is not to stop marketing their products up to 1 year of age, but actually they are very heavily vested now in the marketing of products all the way up to 3 years of age and beyond. The so-called toddler milks for 1 to 3 years have really become a huge market all over the world, including lower income countries. So the industry uses numerous mass and individualized marketing channels. Their strategy is based on maximizing the number of women they reach and the number of times they do it. They're getting now to the moms since pregnancy, even selling formulas to them that are packaged in a very similar way as the one that their babies are going to be, the ones that they're going to see the marketing for their babies. As a result, they achieve a constant flow of contacts with pregnant women and nursing mothers in public, private, as well as all kinds of digital spaces. Marketing convinces women and their families of the need for a wide range of commercial milk formulas which are extraordinarily expensive. And industry is doing very, very strong investments in marketing, again, of products for children from 1 to 3 years old, the so-called specialized commercial milk formulas, supposedly for allergies that are oftentimes misdiagnosed. The evidence is very clear that we are totally over-prescribing this type of specialized formulas for babies with the pretext that they have allergies. They are selling now a peace of mind to parents by supposedly selling products that calm the babies and help them sleep for longer since they are born. And again, they have now gotten into the market of commercial milk formula for pregnant women. And it is very interesting in this graph as to how among those who were aware of the follow-on formulas or toddler milks, the vast majority, the great majority, 95, 93%, and so on, perceived that they were actually needed, when in fact, babies can switch into regular cow's milk as soon as they are a year old, if not sooner, and the very ultra-processed toddler milks loaded with other sugars, artificial flavors, artificial colors, and so on, are totally, absolutely a waste of money for families because they are not needed. In summary, the commercial milk formula playbook targets parents and their aspirations, exploits uncertainties about human-infant behavior, especially in relationship to crying, to a little bit disorganized sleep during the first weeks after the babies are born, and also with regards to what is a really normal, acceptable regurgitation of milk without meaning automatically that is happening because the babies have developed, for example, to something that the mom is eating and is being passed to the baby through breast milk, which is oftentimes what the docs will tell the customers. The marketing is very misleading, is very sophisticated, and it fully understands how to use behavior change science to call the attention of the caregivers. And at the same time, it targets health professionals and has been very successful at influencing broader social norms. So these are examples of how these products send these not so subtle messages that shape aspirations and perceptions of the caregivers when it comes to infant feeding. And the vast majority of health claims that they make are unsupported by scientific evidence. The 3 products above will claim that the product addresses colic, reduces crying, that parents can see results within 24 hours after they start using the product. And in fact, the product to the right, the Amazing Milk, top right, not only promises that babies will grow more and be healthier, but that they will sleep better and be happier. I just don't know what study supports and how they measure that babies were happier with their product. They use very scientific terminology. This really, DHA, fatty acids. It has probiotics, prebiotics, and all this language that, together with the beautiful packaging that they use, it really presents these products as magical and that you really have the properties and the benefits that they offer. The one in the middle, OptiMilk, for example, it claims it's for babies that are fussy, that have gases, that cry. Well, that's really all the babies in the world. That's total normal baby behavior. That essentially is how they communicate, how they express discomfort, needs, and wants. And at the end of the day, it's really important for their standard. and to address it without having to undermine breastfeeding. The products at the bottom, of course, promise that babies will become geniuses because of these magic substances that they have added to these formulas, some of which supposedly are identical to the ones found in breast milk. The problem is that they may add one or two of those when human milk may have dozens or hundreds of them. And there's actually no proof, there's no scientific evidence that they will improve the IQ to the same extent or at all in comparison to breastfeeding. Making claims like the bottom right, that by 2.5 years or so, like this girl really learned to read because of this product, that this commercial milk formula designed for the Chinese market, but using terms like European formula or made with milk from cows from New Zealand and stuff like that, with human milk oligosaccharides and all that, that jargon, that scientific language. The one in the middle, for example, at the bottom, the advanced IQ one, it says, this is a cautionary note that not all the claims made in the product have been proven scientifically. Then you wonder where on earth are the regulatory agencies that are allowing for this to continue to happen. And in general, these products send a message that every drop counts. The more your child drinks, that your baby drinks, your toddler drinks this product, the stronger the benefits and the IQ is going to be. So in essence, what they're saying is our product is really close to breast milk. Some of them really, if you read carefully what they're saying, it can be interpreted that they are not closer, but they are the same or even better than breast milk. They claim their components are driven by science or the composition, the greater intelligence. This product will bring comfort. It says fuzziness, crying, colic, improves sleep, resolves allergies. And so we, as parents, during this period of time, we are experiencing a lot of psycho-emotional issues, concern, and so on. And that's why this type of marketing is known as exploitative marketing that takes advantage of the psycho-emotional concerns that parents have during a very vulnerable. The misperceptions of what are healthy infant behaviors as being unhealthy has enormous consequences for the decisions that caregivers made. And we know that once they start introducing commercial milk formula products, these are going to disrupt the breastfeeding process. And as documented in the Lancet series, that could lead to the self-reported insufficient milk, which in turn leads to more use of commercial milk formula until this visual cycle ends, totally destroying the process of breastfeeding. The way the playbook works for capturing scientists and professional organizations and providers and so on is through an echo chamber approach, where at the heart of this chamber are the scientists, prestigious academic institutions that take money from them to conduct research that is oftentimes a minefield of conflicts of interest. And this way they get easy access to professional organizations. And then the professional organizations are the ones that are shaping the thinking of the healthcare providers, who are still very much respected and are listened to by the caregivers or the consumers. And across these layers of the echo chamber, the commercial milk formula has managed to create formidable conflicts of interest that once people are trapped on them, it's almost impossible to get out. Cycle. This is why it is so important for the American Academy of Pediatrics and academies of pediatrics, nursing, OBGYNs, midwives, and so on, all over the world, to really understand the damage that this conflict of interest is having on the people that they are supposed to be serving with evidence-based information, and especially with caregivers that want to breastfeed and they're absolutely not being able to breastfeed for as long as they want. So the companies shape the narrative by claiming, yes, breastfeeding is the best, but just in case, here are our products, which are good as human milk is. They deny or erase corporate influence or responsibility. They shift the blame to individual responsibility. It's a lifestyle choice. It's up to people to decide. The governments have no role on telling people what to do. They fuel moralizing debates among women's groups. They sow doubt about science, deploy legal tactics. And this is not new. The tobacco industry, the pharmaceutical industry, they all use this approach. What is different is just the incredible tender stage of life at which these really, really harmful marketing behaviors are happening. It is very sad that the commercial milk formula industry playbook in terms of capturing policy has worked really well. In fact, the US government, including the Republican, Democratic administrations, right and left, have managed to weaken or undermine globally the capacity of countries to actually regulate the marketing of commercial milk formula products. Why do the companies do this? Well, because it works. The companies sold about $56 billion in 2019. The vast majority of profits go to the US and a few other high-income countries, and the brunt of the public health damage happens in lower-income countries because they have more babies, they don't have clean water and other infrastructure advances that high-income countries have. This is totally the legacy of colonialism. And even though several reasons explain infant feeding decisions, marketing is compelling, and this is why the companies are spending at least $3 billion per year in marketing, and this is more than the budget that the World Health Organization has combined for advancing for health promotion and for universal healthcare insurance. And please note in these graphs that the sales of products is growing dramatically, especially in lower income countries, and it is what babies are consuming, but the sales per capita, how much commercial milk formula products is each baby consuming, is going up as a result of this very efficient. So just to conclude, it is clear from the Lancet series that interventions must address all levels of the social ecological model to create the enabling environments. They need to be addressing structural issues, the setting issues, as well as the dyad interactions. Thankfully, we do have very well codified evidence-based interventions that can be deployed through healthcare systems, through the labor sector, and of course, the regulation of commercial milk formula marketing that in the short and medium term can help make a difference, but in longer term, we need to make those structural changes happen to address the broader inequities or structural barriers that are keeping the great majority of women that want to breastfeed for as long. So in conclusion, building a new infant feeding system must be centered on concerns of those most affected by the neocolonial systems of exploitation. Aboriginal communities and other minoritized community members must be part of the decisions on how to go about addressing the violent disruptions that their communities have experienced. And the first food systems need to be restructured, having an equity-centered global health decolonizing framework. And I would argue that breastfeeding is indeed the mother of the first food system. So it's key to recognize the importance of breastfeeding for all governments to keep doing that, to recognize breastfeeding as a human right of the diet, and for commercial milk formula to be banned without affecting the production or availability, banning the irresponsible, unethical marketing that is taking place. We now have, through artificial intelligence, the capacity to detect code violations through the Vivid software developed in Vietnam that is being piloted successfully in Mexico and Argentina, and that hopefully this system will spread like fire globally to make sure that we hold governments, and in turn they hold the commercial milk formula companies accountable for they're doing through digital media. Breastfeeding is definitely a collective responsibility. It's not just a responsibility of women. Governments have an obligation to invest in systems that protect, promote, and support breastfeeding. Otherwise, even if we regulate marketing, the approach is not going to work. And multi-sectoral coordination is absolutely. There is no doubt that breastfeeding as access to food and nutrition, there are many, many powerful lobbying infrastructures that the companies have set up across agencies, countries, and so on. They use very powerful arguments against the need for code implementation. And UNICEF has recently published this wonderful and thoughtful report on how can countries and all of us counteract or respond to those issues when they are. Thank you very much for your attention, and I think we have about 10 minutes for questions and answers. Thank you very much.
Great, thank you. That was a very interesting talk. I very much enjoyed that. Is anyone here on the call have questions? I see a bunch of clapping. If people have questions, please just unmute yourself and ask. I was very interested to hear about this and understood some of these issues, but not to this extent. A couple of things that I was particularly interested in thinking about as it intersects with some of the things that I think about a lot are these issues related to policies in our communities and in our workplaces that support or don't support breastfeeding, and also thinking about social networks and social norms and how that influences support for breastfeeding or formula feeding or mixed feeding, or things like that. I know I've definitely talked to people in my personal life and for the research participants in studies who have been actively discouraged from breastfeeding from their communities or been shamed for using formula for a variety of reasons. So I really liked your thoughts about the sort of multi-level intervention, and thinking about intervening about multiple levels. Thinking about us all also as individuals. What would be your recommendations for how each of us in our personal lives or in our professional lives could advocate for a better system?
Great, fantastic question. First of all, in my view, and I think I represent the Lancet series co-authors when I say this, it is a right of women to decide how the hell they want to feed their babies. And whatever they decide, it's important that it is an informed decision and that they get supported no matter what. This is not an issue about shaming any woman or any healthcare provider or any politician. This is an issue about shaming the systems that are responsible for how the commercial determinants of health have been obliterating the public health across the life course, and how they are now obliterating the health of our planet. The commercial milk formula sector is one of the many sectors that form part of what we call the commercial determinants of health structures. As I said, I am very biased. I've been a breastfeeding researcher for over 30 years, but it also happens to be an incredibly, extraordinarily sensitive period of time that will set the course for the rest of the life and development of human beings. Secondly, in Latin America, for example, the vast majority of women, 93 to 98% of women across countries are initiating breastfeeding. It's not like women don't want to breastfeed. And the great majority of them cannot breastfeed for as long as they want. So that is really to whom this work is being addressed the most. And what we are finding, what the evidence is telling us, is that there is no magic bullet. There is no single intervention. You have countries like England that have very generous paid maternity leave, and they have really bad or really low breastfeeding outcomes. But you need a set of interventions, packages of interventions. So you have the baby-friendly hospital initiative when you think about the healthcare system. You have breastfeeding counseling when you think about the WIC program and the community settings. You have paid maternity leave when for sector, we have breastfeeding accommodations at the workplace, including the availability rooms or flex schedules or whatnot. We also have to address social norms, right? The companies have been really successful at changing them. So in the US, and I don't want to get into the nuances of this issue, but in the US now, the great majority of women actually express milk and feed their express milk to the babies versus breastfeeding directly from the breast. That's a very big shift also in social norm. And there are many studies that have been done and many conversations that are taking place. But at the end of the day, it is really to co-design with the key actors in the communities, and of course, women are very, very central actors as to how should these interventions be implemented in their context, in their settings. What is likely to be, stigmatizing? What is likely to be non-stigmatizing? How do we go about changing the minds of the public opinion about, this is a responsibility of all of society and not just of women. If that happens, then that's going to get to the ears of legislators, of decision makers, and so on. So that's why I said that it really requires reforming, making enormous structural changes at the end of the day, a long term, for women to implement their right to breastfeed for as long as they want. And I'm not even saying as recommended, but as long as they want.
Yes, absolutely. Those are some really great additional points. Does anyone else on the call have any questions?
And if I can add something about maternal employment. So as you know, the US is the only high-income country remaining in the world that does not have a federal mandate for paid maternity leave. It's zero right now, right? And in lower income countries, most of them, may have, let's say, 3 months of paid maternity leave, but then the great majority of women in those countries work in the informal economy. So they have zero social protection. In practical terms, they don't have any paid maternity leave. So we have also been publishing work on how much it would cost to provide a cash transfer to moms working in the informal economy, which is mainly an issue in lower income countries, so that it could be the equivalent of their maternity leave. And it was very sad, but we saw what happened during COVID with people that were in the informal economies. They could not stay home. They could not. They needed to sell some. They don't have anything. They had nothing, right? So these estimates, we have done it for Mexico, for Brazil, for Ghana, for Indonesia, for the Philippines, and so on. And country after country after country, those cash transfers would be totally countries. It's a really, really tiny percent of the gross domestic products of those countries. So that's the other sector that we have to keep in mind when we want to take equity into account and when we want to understand the legacy of colonialism as well.
Yeah, I think that those are some additional really wonderful points. And it, have some also sort of inspires some really interesting ways that we could think about, breastfeeding, but also care of infants as work and see that and value the work that is done in the home equally to work that is done outside the home in different settings. I think there's some additional parallels, and connect actually to the Surgeon General's advisory this summer about parental mental health and well-being, with a real push for, valuing, the work that is done caring for children, starting from birth, including feeding them, including breastfeeding, and all the way up for parents who are doing that full time. So I think there's a lot of, really wonderful things that we can think about and a lot of innovative approaches we can think about to tackle this challenge, which, as you said, is a challenge and has influences at a whole bunch of different levels. So, fantastic. Thank you again so much for coming and sharing, your work and talking about this important topic. I know I enjoyed it, and it sounds like in the chat, other people did as well. So with that, I will we'll close this out. But thank you very much, and we appreciate it.
Thank you. Take good care. Bye, everyone.